In Lesson 7, the learning objective, is to begin to learn to recognize when there is an alternative explanation to direct cause and effect for the drug or clinical condition in an actual case series. Here we consider an unexpected adverse reaction highlighted by statistical disproportionality, diltiazem and rhabdomyolysis. In the second quarter of 2010, diltiazem, a calcium channel blocker, and rhabdomyolysis was statistically prominent from the background data in Vigibase, and there were 55 reports. Does diltiazem cause rhabdomyolysis? It certainly wasn't listed in product information at the time, and it was a drug that had been used for some years. If we look at these case reports, we can see a common pattern. If we look at the medicines the patients were taking with diltiazem, they were all taking some simvastatin, and some were taking some other medicines as well. We know that rhabdomyolysis is a severe myopathy and often fatal. It's a known dose-related reaction to simvastatin, but it occurs very rarely at standard doses. The risk is increased with interacting medicines, increasing exposure to simvastatin through inhibition of the CYP3A4 enzyme. The reports suggest that simvastatin was the cause of the rhabdomyolysis. So was diltiazem just an innocent bystander that is commonly prescribed with simvastatin? That is the question. Did diltiazem have a role? Now, we do know that diltiazem is a weak CYP3A4 inhibitor, but it's not thought to interact to a clinically important extent with standard daily doses of simvastatin. In this slide, we have some more information. Take a minute to reflect on it. Think of the ways in which rhabdomyolysis might have been triggered in these reports. Firstly, consider the simvastatin daily doses. In all except one report, the doses exceeded the standard daily dose of simvastatin, which is 20 milligrams. At the time of this signal, cardiologists were encouraging the use of increasing doses of statins to reach ideal low-density lipoprotein cholesterol blood levels. At these doses, diltiazem may have interacted to a clinically important extent. Also, in the first report, the combination of gemfibrozil and simvastatin would have increased the risk of rhabdomyolysis. In the last report, rhabdomyolysis occurred at a surprisingly low dose of simvastatin, but cyclosporine is a potent CYP3A4 inhibitor, and colchicine can also cause rhabdomyolysis, so diltiazem probably didn't have a role in this patient. In 4 of the reports, an interaction between simvastatin and diltiazem is possible. In this case series, there is an alternative explanation to diltiazem causing the rhabdomyolysis. So again, to ask our question, is there any other way of explaining this set of data? Yes, there is. Evidence suggests that diltiazem didn't directly cause the rhabdomyolysis, but it occurred because there was a clinically relevant interaction with it when simvastatin was taken at greater than standard daily doses. And so in conclusion, the case series re-emphasizes that we must consider every variable, that is, the characteristics of the drugs implicated, the patients affected, the adverse reactions reported, and the outcomes. We must gather and evaluate all available data, and with the help of guidelines, weigh up the evidence to reach the most probable answer to, did the drug do it?